By way of introduction, I'm Shalmali Joshi, assistant professor in the Department of Biomedical Informatics at Columbia, affiliated with computer science. My background is in machine learning for healthcare, and I have some interest in algorithmic equity, and so in healthcare, I'm going to talk today about a walkthrough through a case study of how we actually think about these problems in the context of clinical healthcare. Some of you have seen some of the parts of the method, so I apologize in advance for the redundancy, but hopefully we'll see some interesting clinical applications now. Okay, so I think this is pretty well known to pretty much everybody sitting here, but if not, we are developing very cool models for AI in healthcare, but what happens in practice is that we haven't seen as much success of these models in many clinical application areas as we would like. And so some of the problems can be distilled down to two major problems of lack of generalizability of machine learning models to different contexts. A very famous example, if you don't know it, is the EPIC sepsis model, which was trained on, it's a proprietary model trained on some data and then deployed at multiple healthcare institutions. And the performance of that model, designed for ICU patients to detect sepsis early so that you could intervene early, the problem was that the model's performance was highly variable across all of those institutions once deployed, and especially worse in institutions where more patients with larger proportion of comorbidities, such as cancer, were being treated. Okay? So this kind of lack of generalizability is obviously a problem in building kind of the trust in these kinds of technologies. Obviously, they're not working for the patients we're designing them for. Lack of equity is the other big problem. We know that these models can kind of replicate different kinds of biases that exist in the data, sometimes introduce new ones. And so we are in this space of not being able to characterize exactly what is happening, and so a lot of the work that we do in the lab is trying to develop tools and methods to get there. And of course, these big problems can have featured very prominently, not only in the AI Bill of Rights, protection of consumers who are affected by AI, but also the executive order and safe, secure, and trustworthy development of AI. Okay, so this talk is about trying to understand sources of disparity in a particular case study in AI in healthcare. So if you want to treat it, to me, it is very much an engineering research problem where if you want to understand the sources of biases, we need to develop tools that can help us quantify. And then once you understand what's going on, you can design new methods to actually account and compensate for them and design better AI systems. Eventually, we get to a place where these AI systems can learn from their own feedback, wherever they are not working well, and then they can be enhanced from how they are performing in practice. Okay? So today, I'm only going to talk about the first piece of it, and I'm happy to discuss more offline. So if you are an AI researcher wanting to dabble in healthcare, you typically start this way. If it's a supervised learning problem, we define a task that we think is clinically meaningful. Predict sepsis early is a task. Diagnose diseases from chest x-rays is a task. And we then figure out a data set that will help us address this task. So we create input-output label pairs. So let's say in the chest x-ray diagnostic case, it's chest x-rays and labels. And then the goal of learning using any kind of learning technology is to be able to automatically extract those labels given the input. If you're looking at generative AI, then you have some joint distribution over the input that you're trying to model and then sample from. Today, we're going to stick to supervised learning. Most of us, coming from the machine learning world, are usually agnostic to this data and label source. And then we create our cool methods, and then we try to apply it in the data and then see what happens to the performance. As Rajesh went through extensively, we typically measure this through AUROCs and retrospective performance metrics that don't always translate to something useful in practice, but that's what we do as a very canonical practice in machine learning. And so the success of deep learning has usually been in being able to extract these very nice representations from high dimensional data that can actually solve a particular predictive task. So the gap here is for us to start to understand that these tasks, these data, these labels are a byproduct of a very complex ecosystem. And so to give a quick example, you are looking at a very tiny snapshot of the data when you're looking at one data set. Some of it is a consequence of many things, such as we are limited by the current state of clinical knowledge. Obviously, that's going to be always the case. We've historically understudied certain conditions. Or maybe there is some form of subtle but systematic discrimination. It's a form of historical bias. Even when you can see certain patients in a particular healthcare institutions, they might be funneled through from some form of selection bias. Different people have access to different levels of healthcare. Their own care-seeking patterns and healthcare utilization is different. And then on top of that, clinical practice varies, and who's screened for what conditions also varies. Creates another level. That's the selection bias. On top of that, even for conditions we do understand very well, we are not necessarily always collecting all data that we might want to see. And we had very good talks on how EHR data needs to be looked at in conjunction with other data sources, such as biobanks, in order to draw conclusions for many conditions. So we're not measuring everything that we want to measure. Even things like socioeconomic status currently don't feature as if it's like 100% available in all sorts of observational data of interest for us to analyze it properly. And then finally, even if there is a specific diagnostic test, we know everything what we need to do for a particular condition, for a given patient, sensing mechanisms, data acquisition devices are different. Now you're going to also look at how we are representing different concepts. One easy example of that is when you look at standard ways in which chest X-ray based diagnostic tasks are done, NLP-based tools are often used to look at clinical note summaries of radiological findings from the chest X-rays, and the labels are automatically extracted, and so there could be label noise induced in that process as well. All of this happens, and then you see the data, and then we are going to train our models. Okay? And so what I'm here to just show you a case of is to suggest that we're going to have to start modeling this ecosystem if we want to build reliable AI. And so we are going to use a paradigm of distribution shifts to start thinking about this problem. These biases are going to be thought of as distribution shifts. We like distributions. We can think of them. We can develop methods and tools around them. But we are now thinking about distributions not within the data that is seen by the model necessarily, but along with that, we are also looking at distributions that are upstream of until when the data is even seen by the model. Okay, so that's the big difference that we are going to start to model. And so I keep coming back to this example. The colors look very different, but okay, hopefully we'll be able to see the plots. Anyway, the case study I'm going to continue through this talk is that of diagnosing pulmonary and respiratory diseases from chest radiographs, a very canonical task that anybody who works in AI in healthcare would just spin up a model and get this to work in maybe a day or two. It's that easy. It's like essentially like the MNIST of AI in healthcare. Okay. And so the idea of this task is to look at chest X-rays and diagnose a patient into 0 or more of these pulmonary and respiratory conditions that you see on the right. And today we are only going to restrict ourselves to pleural effusion and no finding. And we're going to dig into performance disparities of different models and what we can glean from what these models are actually doing. Okay? So now if you start to think about the data ecosystem, let's think of a patient who has some complaints, goes to the ER or emergency department, and then they go to the nearest hospital. So obviously the data in that hospital is a form of who has access to which healthcare institution. Once they entered that hospital, they complained about something. The clinician provides an initial impression or a differential diagnosis, which essentially determines and their demographic themselves will essentially determine which views of the chest X-ray are collected. If they're very old, they can't even stand, the X-ray will be collected sitting down or lying down. So these kinds of demographics will influence what kind of samples are collected for that patient. Now the radiologist looks at the X-rays and comes up with a clinical note which gives the final finding and the general impression of what they're seeing in the chest X-ray. Then there's an NLP tool that hovers on the clinical notes and then extracts the label. Those are the labels that you're going to see here, and we're going to now train a deep learning model that is going to look at the chest X-rays and try and diagnose these conditions. So this is the high-level case study. Now I'm going to tell you the method that we're going to use, and then we're going to then come back to the case study and interpret some of the disparities in these two particular labels. Okay, so what we're going to talk about is a method to look at lack of generalizability and equity and try to attribute them to upstream distribution shifts that might be responsible for these disparities. So if you are familiar with terms in software systems, this is like a root cause analysis, but for AI systems, okay? And so by doing this exercise, it's not just about trying to understand sources of lack of generalizability or lack of equity, but it's also a way to understand how far can we go in physiologically interpreting what's happening with these models when we are using them in some predictive tasks. Okay? Kind of, that's where I want a note of caution is we need to be very careful. And so let's formalize this very quickly. I'm going to go through the method in not a lot of detail, given the amount of time we have, but hopefully I'll cover the high-level gist of it. So we have a system of variables, x and y. A subset of those variables is going to be used by the model to do the prediction. So in the X-ray task, the X-ray itself is the only thing that the model sees. Everything else, the patient demographics and insurance and which views were collected, all of that is not seen by the model. Okay? And the model is trained as is, and we care about the loss of the model. Let's say we took data from one hospital, and the loss is script L. In the second hospital, we tested the model without training it on data on that second hospital. And then we see that the loss is a bit worse, so the model is deteriorating a little bit. So our goal is going to be, how do we attribute this change delta to these distribution shifts that might have happened going from source to target? And we are going to assume that we have samples from both the source and the target to do this job. The way to think about it now is I'm going to run through with a very toy way of representing the data, which is that we're going to model all of this upstream complex ecosystem data generating process as in the form of a causal graph. The benefit of that is nothing special. We're not doing any sort of real causal inference. The benefit of that is just for us to be able to understand which distribution shifts should we care about in terms of figuring out where the differences come from. Okay? So to formalize this specifically, let's think of a system of variables with just 3 variables, x1, x2, and y. And I'm going to give them some meaning, but it doesn't really mean anything. In this case, let's say both x1 and x2 are being used to solve the prediction task, which is to predict y. And then you formalize the loss that we care about. There's a source distribution that we'll call d source, and the loss there is script L. And then the target distribution is the same loss calculated from the samples in the target data, which is we're going to call d tar. And the loss is, of course, higher by delta. This assumption that we can codify the ecosystem in the form of a causal graph or a structural causal model essentially just tells you that the joint distribution over the data or over our variables of interest can be factorized into a certain form. And that factorization is what we are going to use to figure out which candidate distributions we want to focus on in terms of figuring out the source of shifts. Okay? So that's basically the idea. So how do we come up with a system that, given only samples from the source and the target, will allow us to figure this out? Where the loss? We need to find distributions to blame for this loss change. And so we could have multiple ways. let's say, now let's give these variables some meaning. X1 is, let's say, age. X2 is the diagnostic test. And age is maybe a factor that is used in determining who gets the diagnostic test. And the X2 is the measurement of that test, and then Y is the outcome. And so it could happen that going from hospital 1 to 2, only the marginal distribution of age is changing, and in which case we would want a system to tell us that only the marginal distribution of age is changing, nothing else is changing, and so all of the performance deterioration needs to be blamed on the age distribution shift. But the reality is more complex, and it could happen that multiple things are changing. In which case, what we want is a system where it says, okay, it feels like P of y given x1, x2 is not changing. So there's no, for those who know the terminology, it's a concept shift. There's no concept shift going from source to target. But the marginal of age and then the diagnostic protocol seems to be different going from source to target and in different proportions. And we need a system that will, we need a method that will take as input any distribution and tell us how much it contributes to the loss. Okay, so that's what we're going to try to do. And so the method is relatively simple. It's just treating these distributions as players in a Shapley game. You might have in your past life or whenever you've done some machine learning development, you might have used Shapley values on the features, but here we are going to use it on distributions. The effect of that is that we are going to be able to figure out the average contribution of any distributions towards the loss change whenever it's used in conjunction with different coalition of players. Okay, so the way this works is as follows. Let me actually just not even go through this. I'm going to just stick to this. The way this works is that we consider all possible subsets of potential distribution shifts. They could be hypothetical. So let's say, and we're going to call them players. Each distribution pair is a player, or members of the distribution set are players. So let's say the set is empty, which means no distribution is changing from source to target. And when no distribution is changing from source to target, we only care about the loss as if all of the intermediate distributions were the same as in the source. And so we care about a loss function where nothing has changed. And so the value of the coalition when you have an empty set is basically the change in loss going from the source to the target distribution. And so the value here for an empty subset will be 0 because everything is the same. Now let's say you have a hypothesis that only the marginal distribution of age has changed, in which case you'll compare the source loss to the loss where only the marginal of age is set to the target distribution age and everything else is set to the source. Okay? And then if you have a set of players where two things are changing, then the corresponding loss that you're going to look at is comparing the loss in the source to the loss in a hypothetical distribution where two of these distributions correspond to the target, but the y given x1, x2 corresponds to the source. Okay? So you can look at arbitrary combinations of distributions and map it to arbitrary combinations of loss functions that you want to calculate. And then you'll always compare how much the loss changes with respect to the source. And then we are going to come up with a way of figuring out how to blame each one distribution based on this idea. And so that's all that happens. Let's say we want to figure out how much is distribution of age contributing to this loss change. We're going to look at all possible subsets of distributions that don't contain the marginal of age. Then we're going to look at how much the loss changes if we added age to any of those subsets. So the subsets that are possible are the diagnostic screening protocol, the disease rate, y given x1, x2, and a set which contains both of these, right? And so then we're going to add age to each of them and see how much the loss changes. And then we're going to average that number. That will tell us how much is age to be blamed for this performance difference. And that's all that's happening here. The question then is, of course, how do we estimate these loss for any of these arbitrary combinations? And so the one way to do this is importance sampling, which is just a way to get unbiased estimates of expectations from samples that are coming from a different distribution. We're going to go over why this can be a problem in high dimensions very quickly. But this is doable. Okay? The important takeaway at this point is this is doable. And so the method has some nice properties in that each distribution that we care about is potentially shifting, will be attributed blame such that the sum total corresponds to the total loss change that you're seeing. If a distribution does not change, then its attribution is going to be 0, and so on and so forth. So these are nice properties to have for the method. Now let's go to what happens in the X-ray case. Okay? So now we understand the setup. We understand what method we're going to use. We understand that there is bias in upstream until you see the X-rays themselves. And so typically, deep learning models are going to use the X-rays themselves to predict the disease. Okay? We're not going to use anything else. What happens is this is well reported, and we can reproduce it very easily, that for the no finding as well as for pleural effusion, there is bias. And the particular bias is that of underdiagnosis. So black patients more often are told they don't have a condition when they do. And black patients are also told they don't have pleural effusion when they the models don't detect pleural effusion when patients do have. So the false positive rates are higher for the no finding, and the recall is lower for pleural effusion. So now we're going to figure out what happens. And here you're seeing the numbers from two different models. One is a DenseNet model that's trained on the data that we're testing. This is mimic data, which is a very canonical data set that from the BIDMC hospital that you would potentially use for such a task. And a priori, it looks like, and the other model is a foundation model developed by Google, which essentially is trained on chest X-rays from multiple healthcare institutions, not BIDMC, and then some hospitals, Apollo hospitals in India as well. Okay? So a priori, the performances look very similar, but then the subgroup performances have patterns of underdiagnosis and then very different kinds. So we are going to repeat this exercise now that we know how to do this. And we are going to form essentially a causal graph, if you will, of the data acquisition mechanism going towards the X-ray. So this consists of the patient demographics, which is confounded by social determinants of health with disease prevalence. All of these influence what radiographic views are collected for the patient. So the directed edges that you're seeing are causal dependencies that we think exist in the system. The bidirected edges is our source of confounding. And then there's measurement bias, which is essentially once you've figured out which views to collect, you see the radiograph itself. Okay? And then the AI model is just this purple bit, which is looking at the radiograph and coming up with a diagnosis. Nothing here up front is seen by the model. So now the challenge to attributing blame to any of these in high dimensions is that we are stuck with massive chest X-rays. And this creates a problem for us when we are actually using methods like IPW or the reweighting to come up with the attributions. So if you do this, if you brute force your way, and this is related to the issues of positivity and lack of overlap that were brought up by Rajesh early in the morning, it's essentially the same issue. You cannot get unbiased estimates of these expectations with samples from different distributions in high dimensions because you cannot expect this kind of statistical overlap to hold. So we're going to give up something to enhance the interpretability of what even is going on. So what we're going to do is we're going to treat the embeddings from the chest radiograph deep learning model as the representation of these X-rays. These are sort of like, you can call them lossy representations that are predictive of the diagnosis but don't necessarily capture everything of essence in the X-ray. And then we're going to treat them as essentially conditionally independent given the parents. And so in order to address these statistical challenges, we made multiple things happen. We looked at the embeddings instead of modeling the X-rays directly or even using IPW style methods because they are statistically challenging to model here. And then we are going to treat these individual embedding dimensions as conditionally independent given these parents. And so now we might be trading off some bias in our attributions, but we gain something in terms of interpretability. And so we attempted this with multiple distributions, but I'm not going to go over it due to time. And then we are going to look at what happens. So if you look at the attributions and the percentages, if you see the number in blue, that number is essentially corresponding to the DenseNet model, and the number in yellow corresponds to the foundation model. Any positive number suggests that that distribution shift contributes positively to the disparity that you're seeing between white and black patients. So as you can see, disease prevalence differences contribute up to 28% of the difference, and then the X-ray shifts contribute to 50% of the difference. So there's a measurement bias significantly that the model is not able to learn from for black patients, essentially likely correlated with age. That is what we are seeing. The other thing I want to say is that the pattern of disparity is different. The foundation model has less disparity compared to the DenseNet model. And the foundation model is such that the measurement bias is sort of lower for the foundation model, and the bias, the attributions are shifting upstream more and more towards things like age difference and so on and so forth, at least in the no finding false positive rate disparity. So that's the other takeaway. So now, if a priori with AUROCs, you couldn't say anything. With the disparity, you can say something. The disparity looks lower, but now you can say more. You can say that the model is actually able to learn. The foundation model, I think, is able to learn better from the chest X-rays than the DenseNet model itself. And then the distribution shifts are really like proper demographic differences, maybe correlated, but that's what is contributing to the disparity. In the case of pleural effusion, again, the model disparity looks higher for the foundation model than the DenseNet model. But if you see the proportions of what's affecting the model, now you will see some negative numbers. Negative numbers are attributions that are helping the model close the true positive rate disparity between white and black patients. A positive number is something that is worsening the disparity. So the big thing that you can see here is that the foundation model's measurement bias kind of increases in the negative direction, which means it's relying more and more on the X-ray signal to learn from for black patients and generalize better. Still, I think this is desirable behavior. But now let's look at what is happening. We still haven't been able to interpret very clearly what's going on, so I'm going to show you exactly what we gained from using these X-ray embeddings. And the thing that we gain is a little bit more of interpretability. And so what we do is we select the top 5 dimensions that explain the disparity in each no finding and pleural effusion, and then map them to image space. And then we are going to see 2 of the top 20 patients we found that the model is most uncertain about, and then look at them in saliency space to see what's going on. We obviously cannot do this for the foundation model because we don't have access to weights. Saliency maps requires access to model weights. And these are GradCam images. I'm going to run through very fast because we don't have time, and I'm already over. Sorry. On the left, you're seeing the saliency map for the prediction that the model index is on. And this is a pleural effusion, supposed to be bilateral according to the clinical note, but the model is looking a little more on the right side of the lungs. But if you look at what explains the true positive rate disparity, it really looks like a spurious correlation. It's outside of the lung area in and of itself. So maybe the model is picking up, what you're seeing is definitely a false negative black patient. So the model is picking up on something spurious in order to actually say that this person does not have pleural effusion. Something similar, these are all patients that the model is very uncertain about. So what happens in the no finding case? No finding case, the top most uncertain patients look like clear cases of label error, where clear cases where there is something present, and most often it is atelectasis that's present, and the model is somehow not able to index on it for some reason. So now you would want the point of this is that you can use different solutions to fix the disparity in pleural effusion than you would for no finding. Because it looks like there's a spurious correlation that's being picked up in pleural effusion, but something else is happening that may be improved by better label extractors for the no finding case. So you can fix these disparities either via computational solutions or better by collecting better data and so on and so forth. And so with that, I just want to stop because I'm very over time by saying that if we have methods and tools that can actually identify causes of lack of disparity and equity, then we can actually go on to understand how do we improve these models, first of all. And then we obviously have to be very transparent about the kinds of assumptions we are making along the way, so that we know exactly what the limits of interpreting from this kind of data are. And it looks like the foundation models are doing something right, as far as I think right now, at least squinting at some of these images. So maybe we are taking a step in the right direction in terms of addressing generalizability and equity. And since I'm out of time for questions, come talk to me offline, and then we'll probably have the next speaker start, who is Rahul, right?